Alright, this is ABSITE and board review for breast, part 2, malignant disease. Let's start off talking about DCIS. Ductal carcinoma in situ develops in the duct tissue, and it is cancerous cells in the lumen of the duct, but those do not penetrate the basement membrane of the duct. Cribiform type is less aggressive. Comedo type is more aggressive. DCIS typically presents as calcifications on mammogram. Unless the DCIS is very widespread, starting with breast-conserving surgery is usually fine. The surgery is usually set up as a wire-localized lumpectomy, since these are usually not palpable. The patient should be counseled that about 20 to 30% of lumpectomies for DCIS have a positive margin. The current recommendations are for 2 millimeters of negative margin for any DCIS. No sentinel lymph node is needed for a lumpectomy for DCIS. If you are doing a mastectomy for DCIS, you should do a sentinel lymph node, since if you find cancer in the breast specimen after surgery, you can't go back for a sentinel lymph node later. After lumpectomy for DCIS, the patient should have radiation. If it is a small area of DCIS, less than 1 centimeter in size in a woman over 65 years of age, maybe radiation can be omitted, but send her to a radiation oncologist to decide. Mastectomy for DCIS does not need radiation. Most DCIS is tested for ER and PR, but not HER2. There is no role for Herceptin in DCIS alone. If it is estrogen receptor positive, most women are recommended to have tamoxifen post-surgery. Paget disease of the breast is when a ductal cancer or DCIS crawls into the nipple, causing what looks like a rash or eczema of the nipple. It is usually diagnosed with a punch biopsy of the nipple skin. It usually requires a mastectomy to remove the underlying lesion. Invasive breast cancer can be invasive lobular cancer in 20% of cases, but the majority of breast cancer is invasive ductal carcinoma. A few subtypes of invasive ductal are cribiform, mucinous, and tubular, and these may have slightly better prognosis, but as surgeons the treatment is usually the same. A few notes on lobular breast cancer. The way that the pathologist determines it is lobular is by lack of staining for the cell-cell adhesion molecule E-cadherin. If E-cadherin is negative and it is a breast cancer, it is assumed to be a lobular. Since lobular cancers lack this cell-cell adhesion, they tend to spread in a single line, single files of cells, and the lymph nodes can have scattered cells throughout the node. A lot of breast surgeons will tell you lobular cancers make us nervous, since they can have multifocal disease and difficult to find lymph node spread. Breast MRI is a good idea in lobular cancers, since their risk is higher in both breasts. Invasive cancers should have markers checked at the time of the original needle biopsy. The needle biopsy tissue is checked for estrogen receptors, which range from 0 to 100%, progesterone receptors, which also range from 0 to 100%, and HER2/neu. HER2/neu is a cell surface growth factor receptor that is checked in two ways. Immunohistochemical staining, or IHC, grades the HER2 expression as 1+, which is negative, 2+, which is equivocal, and 3+, which is positive for being overexpressed. Most will recommend FISH, or fluorescence in situ hybridization, for at least the equivocal ones on a IHC testing, but some pathologists do FISH for all HER2/neu testing. 20% of breast cancers are HER2 overexpressed. Ki-67 percentage is a marker of the rate of mitosis. Less than 10% is pretty good. Once the Ki-67 is in the 25% and over range, we consider that relatively high and a sign of more aggressive growth. Some oncologists like blood levels of Ca 27.29 in breast cancers. Okay, let's talk about breast cancer surgery. Lumpectomy breast conservation, partial mastectomy are all basically the same thing. Lumpectomy is indicated if the tumor is less than 5 centimeters in size, is unifocal, and if the breast to tumor ratio will allow for a good cosmetic outcome. Since most invasive breast cancer treated with lumpectomy really should have radiation, you should also be sure somebody can have radiation after surgery. If somebody has had previous breast radiation or cannot have radiation because of a skin disorder such as scleroderma, then a lumpectomy is not a good idea. Having tumors in different quadrants of the breast is called multicentric cancer. And generally, you should say this is a contraindication to lumpectomy. Multiple tumors close to each other in the same quadrant can be called multifocal. And theoretically, a large lumpectomy or a quadrantectomy could get all of them out as long as the cosmesis is appropriate. If you can field the tumor, you don't need wire localization. If you can't field the tumor easily, then you can have a wire or a seed localization or do an intraoperative ultrasound. Wire localization is probably the safest answer. It is always good to confirm that the clip from the biopsy was in a good location where the lesion actually was, per the radiologist, who usually does a post-biopsy mammogram to confirm this. If wire localization is used, usually the specimen is sent for radiograph during the surgery to be sure the clip and mass are actually in it. The pathologist will give you the total size of the tumor, and the current rule is if there is not any tumor touching the ink from the pathologist marking them, then you are considered to have clear margins. If there is coexisting DCIS and invasive cancer, no ink on tumor can be used to trump the 2 millimeter margin needed for the pure DCIS. I know it's weird. I would generally assume that every lumpectomy for breast cancer will get whole breast radiation. Occasionally, a very small, less than 1 centimeter tumor in an older, greater than 65-year-old woman may skip radiation. Generally, we quote a 50% local recurrence risk at 20 years without radiation. This goes down to about a 10% local recurrence risk at 20 years with radiation. It makes a really big difference. The study that showed this was the NSABP-B04 trial. Mastectomy can be a simple mastectomy, which is removal of just the breast. And this can be skin sparing, which means trying to keep as much skin as possible, or non-skin sparing, which just means taking as much skin as you can. The nipple-sparing mastectomy leaves all of the skin and the nipple. Nipple-sparing mastectomy can be done from a periareolar or an inframammary fold incision. Don't do nipple sparing if the tumor or DCIS is really close to or involves the nipple. Most surgeons do frozen sections during the surgery of the subareolar tissue to double check this. It is generally acceptable to do nipple-sparing mastectomy for BRCA patients now also. The average mastectomy removes the nipple with an ellipse of skin. A Halsted radical mastectomy removes the breast, pectoralis muscle, and the axillary nodes. The modified radical mastectomy just removes the breast and axillary level 1 and 2 lymph nodes, hence the term modified. The indications for mastectomy are patient preference, tumors over 5 centimeters in size, multicentric tumors, widespread DCIS or LCIS, widespread malignant calcifications on imaging, high-risk genetic mutations, among some others. Remember that inflammatory breast cancers, pathognomonic finding is dermal lymphatic infiltrate with cancer cells. The breast tends to present with a red and swollen skin, termed peau d'orange, since it looks like an orange peel. The treatment for inflammatory breast cancer is always chemotherapy first, then a modified radical mastectomy with full axillary dissection, then post-mastectomy radiation. After a mastectomy, the majority of women do not need radiation. Indications for post-mastectomy radiation are tumors over 5 centimeters in size, so T3 or more, inflammatory breast cancer, or T4 breast cancers that invade the skin or chest wall and have multiple involved lymph nodes. We used to say 4 or more involved lymph nodes, but some radiation oncologists are giving post-mastectomy radiation for even 2 or more involved lymph nodes. When a radiation doctor gives radiation after a mastectomy, they usually include the supraclavicular lymph nodes and the internal mammary lymph nodes, along with the entire chest wall and axilla on the side of the cancer. Post-mastectomy reconstruction can be immediate or delayed. Immediate happens at the same time as the surgery for the mastectomy. Reasons to do the reconstruction in a delayed fashion may be fear about poor healing due to patient factors such as diabetes, obesity, smoking, or wanting to get the patient on chemotherapy as soon as possible. Or the patient may be needing post-mastectomy radiation, since radiation tends to affect the cosmesis of the reconstruction. Types of reconstruction are implants, placed either behind the pectoralis or prepectoral. Post-radiation, a common surgery is the latissimus flap that brings a pedicle of skin from the back along with the latissimus muscle to the front. Less common flaps are the DIEP, which stands for deep inferior epigastric pedicle, and gluteal free flaps. These are done by specialized microvascular plastic surgeons. Let's go over lymph node management. As mentioned before, lymph nodes don't need to be sampled for phylloides tumors, not for a DCIS having a lumpectomy, not for LCIS, not for excisional biopsies for atypical hyperplasias. Pretty much you only need to worry about the lymph nodes in invasive breast cancer. If lymph nodes are not palpable, then the patient will probably need a sentinel lymph node biopsy. This is done by injecting nuclear medicine lymphoscintigraphic dye, such as technetium-99 or Lymphoseek, into the breast, and also lymphozerin blue, which is injected by the surgeon. One or both dyes are used by surgeons, although personally I think there is a less false negative rate with using both the radioactive and the blue dye. I send the sentinel lymph nodes from the lumpectomy surgery for permanent pathology, and I only do frozen section on the sentinel lymph node from a mastectomy. The reason is that with lymph node metastatic disease that has no extranodal extension in 1 to 3 lymph nodes, that good data from studies such as the ACOSOG Z11 show that you do not need to do a completion axillary lymphadenopathy, lymphadenectomy, if the patient is having a lumpectomy with the plan to do postoperative radiation therapy. So, there is no reason to have a frozen section done during a lumpectomy, since it does not change your surgical management during that surgery anyway. With a mastectomy, however, I do a frozen section, and if there is metastatic disease in the sentinel lymph node, I do the completion axillary dissection during the mastectomy. Chronic lymphedema is treated with compression sleeves, usually 20 to 25 millimeters of mercury pressure. Purple nodules growing rapidly on an arm with chronic lymphedema is concerning for Stewart-Treves syndrome, which is an angiosarcoma. It's usually very aggressive and often needs amputation. Briefly, let's discuss chemotherapy. Adjuvant chemotherapy is given after surgery and prior to radiation. Giving radiation at the same time as chemo is too toxic. The decision for chemotherapy is usually made after the pathology from surgery is available. For ER-positive, HER2/neu negative cancers, many oncologists use a test called the Oncotype or the MammaPrint, which tests multiple genes to give a risk recurrence score that will tell them if the patient needs adjuvant chemotherapy. If no chemo is needed for an ER-positive, PR-positive tumor, then the patient will get radiation, then takes tamoxifen if they are premenopausal, or an aromatase inhibitor if they are postmenopausal. Prior to menopause, the estrogen comes from the ovaries, so blocking the estrogen at the end receptor in the breast works best, which is what selective estrogen receptor modulators, or SERMs, such as tamoxifen, do. After menopause, the estrogen comes from peripheral conversion in fat tissue, from pre-estrogens to estrogen, using the enzyme aromatase, which is why aromatase inhibitors work after the ovaries shut down in menopause. Tamoxifen increases the risk of endometrial cancer, DVT, and cataracts. The side effect risks of aromatase inhibitors are less as far as thrombotic and endometrial hyperplasia, but they do cause musculoskeletal pain sometimes. Neoadjuvant chemotherapy is given prior to surgery. As a general rule of thumb, I would have the patient see a medical oncologist prior to surgery to consider neoadjuvant chemotherapy in all patients who have inflammatory breast cancer, palpable axillary or supraclavicular nodes, skin or chest wall invasion, or tumors over 5 centimeters in size, especially if the patient wants breast conserving surgery. ER-positive, HER2-negative tumors may not have as much response to chemotherapy prior to surgery, but at least discuss in the patients mentioned above. You should also assume that all triple-negative and HER2-positive breast cancer will need some chemotherapy at some point. Neoadjuvant chemotherapy is usually strongly considered in triple-negative and HER2-positive breast cancer. The cutoff for giving chemotherapy prior to surgery for these is usually any tumor over 2 centimeters in size or positive lymph nodes. Common drugs for triple-negative, which are ER-negative, PR-negative, HER2-negative, are adriamycin and Cytoxan. For HER2 overexpressed cancers that are bigger than 2 centimeters, the regimen now is TCHP, which is Taxotere, Cytoxan, Herceptin, and Perjeta. The Herceptin and Perjeta are both antibodies against the HER2 protein itself. These are also cardiotoxic. Adriamycin is also cardiotoxic, so they are not usually used together. Echocardiograms or MUGA scans are commonly checked before and after cardiotoxic chemo such as these. After chemo, the tumor is restaged with imaging and then usually undergoes surgery. It is acceptable to do breast-conserving surgery if the tumor has shrunk or can't even be seen anymore. If the lymph nodes were involved prior to surgery, the safest answer is to do a full axillary dissection after chemo. But if there is a great radiographic response to chemotherapy, then there may be a role for sentinel lymph node biopsy. This is an ongoing debate. After the surgery, the pathologist will tell you if there was a complete pathologic response, meaning that no cancer is found in anything surgically removed. This is denoted on path reports with the prefix YP, so YPT0N0 would be no residual tumor after neoadjuvant chemo. If there is residual tumor in the breast, it is more likely that the patient will continue with more chemo even after surgery. The HER2-positive breast cancers are usually continued on Herceptin antibody for 1 year total. Briefly, let's mention gynecomastia and breast cancer in males. Men get gynecomastia in infancy, puberty, and after age 50. This tends to be concentric, rubbery masses below the nipple. Some medications can cause gynecomastia, such as spironolactone, marijuana, renal disease, and cimetidine, as well as liver failure and some testicular tumors that can make estrogen. The full workup for gynecomastia should include renal and liver function tests, medication review, testicular exam for a mass, serum beta-HCG and estradiol and testosterone levels. But I would only really do all of this if the gynecomastia seems unusual. It is not considered a risk factor for breast cancer and can be evaluated with mammography and ultrasound. It can be treated with tamoxifen or surgical removal. Male breast cancer, on the other hand, is hard and eccentric away from the nipple. Male breast cancer can be associated with the BRCA2 mutation and it is an indication for genetic testing. Workup is usually a mammogram and an ultrasound and then a biopsy. For a test, I would answer that male breast cancer gets a mastectomy with removal of the nipple. Sentinel lymph node biopsy with a frozen section and possible axillary dissection if the sentinel node has cancer should be a safe answer. Most male breast cancer is ER positive and HER2 negative. The last high-yield topic is breast cancer and pregnancy. The basic rules are that you can never give radiation to a pregnant woman. You can give chemotherapy after the first trimester. You can never give hormone blockers when pregnant. And that you should not wait more than 3 months after surgery to give radiation. Using these rules, you can probably figure out most of the questions. So here is some basic scenarios. Breast cancer in the first trimester needs a mastectomy, since you will still have 6 months until the radiation can be given. Early second trimester probably should be treated similar to first trimester. Breast cancer in the late second trimester, you could do a lumpectomy, then give chemo for 3 to 4 months, then give radiation just after birth. Third trimester breast cancer can be treated safely with lumpectomy, then chemo, then radiation, without overlapping much with the pregnancy. Okay, well, that was a lot. I hope that helps.